Good evening, everyone. Thank you so much for joining today. I'm just waiting for everyone to join us. Give us a few seconds. Great, so I'll get started now. Thank you so much for joining us tonight for our latest medical sciences lecture titled Type 1 Diabetes, Exciting New Developments in Treatment and Prevention. My name is Nora, and I'm a current fifth-year medical student here at UCL and your chair for today's event. In today's fascinating lecture, Dr. Miranda Rosenthal will discuss the exciting new developments and the new treatment options for those living with type 1 diabetes. We want to keep these lectures as interactive as possible, so please use the question and answer function on Zoom to submit your questions for our speaker, Dr. Rosenthal. The question and answer function should be below, so please do submit as many questions as you want. We love your questions. And of course, we have a world-famous physician here to answer them. So please use this opportunity to ask as many questions as you want. We also have a hashtag for the event. It's hashtag FMS Lectures on Twitter. So please tweet about us using the hashtag FMS Lectures. This lecture will be recorded, and a link to the recording will be sent out via email to all the attendees after the event. Before I introduce our speaker, we would like to know about our audience. So we ran the following poll, asking you to select the group you consider you belong to. So you should see an audience poll right now on your screens. Please vote according to which population you belong to. So whether you're a prospective student, an undergraduate student, a postgraduate student, a PhD student, any academics, or any patients or carers, any other, please vote. This is always so exciting to see. Just knowing more about who's attending and everything. We should have the answers soon. All right, thank you so much for everyone who voted. I just have the results here. So it looks like 59% of you are prospective students and families. So that's really exciting. I hope you get into UCL next year. Some of you are undergrads, fantastic. Some of you are also other types of students. So postgraduate and PhD students, really, really exciting to see. Some of you are academics and also patients, which is really, really exciting. And some of you are other. I wonder what that is. Really cool. Okay, so now I'm very excited to introduce our speaker. We have Dr. Miranda Rosenthal. She has a special interest in the mechanism and treatment of hypoglycemia in type 1 diabetes and has extensive experience in the use of continuous subcutaneous insulin infusion and continuous glucose monitoring. Her research interests include etiology of type 1 diabetes and also treatment of eating disorders in diabetes. Thank you, Dr. Rosenthal, for joining us today. Now over to you.
Thank you very much. So, as Nora said, I'm a diabetes consultant and an associate professor at UCL. And today I'm going to talk a little bit about what type 1 diabetes is, what the current treatments are and where some of the developments are as well, and what we can be thinking that we're going to be experiencing in this space in the next few years. So diabetes, what is it? Diabetes is a group of disorders which are characterized by a high blood glucose level. And what they do as a group is high blood glucose levels are associated with the development of certain pathological conditions, such as kidney disease, damage of nerves, damage of eyes. But diabetes is caused by a variety of dysfunctions. And the one that is related to type 1 diabetes is insulin deficiency. But the more common form of diabetes, which is type 2 diabetes, is mainly related to impaired effectiveness of insulin action. And this panel here is taken from a Diabetes UK awareness campaign a few years ago. And they were trying to make the point that with diabetes, when the blood glucose levels are high, people can sometimes feel quite well. But over time, these high levels can damage the body. And therefore, the whole idea behind the management of diabetes has principally focused on trying to bring those blood glucose levels into a threshold range where damage is minimized. So what happens with type 1 diabetes? So this is a diagram showing the pancreas. The pancreas is in the abdomen, and it's related to the first part of the small intestine. And the pancreas has two functions. It releases insulin into the blood, and it also releases enzymes into the gut. The diagram of the islet of Langerhans, these are nests of cells that represent about 1% of the mass of the pancreas. And they have various different cells, and we're interested in the beta cell. The beta cell has insulin producing cells, and it represents about 1% of the total mass of the pancreas, so a very small amount of the pancreas. And in type 1 diabetes, these cells are damaged by an autoimmune process. So looking at the far panel, the area with the brown staining is staining for insulin, and the area with the blue staining is T cell, which are damaging the beta cells, and these are part of the immune system. We can see these in people who are developing type 1 diabetes. So type 1 diabetes is a serious condition where your blood glucose level is too high because your body can't make the hormone called insulin. The body destroys the cells in your pancreas that make insulin, and insulin allows the glucose in our blood to enter into the cells. And when you have type 1 diabetes, your body will still break down carbohydrate from food, and carbohydrate is substances such as bread, potatoes, from food and drink, and turn it into glucose. But when the glucose enters your bloodstream, there's no insulin going, allowing the sugars to go into the body's cells. More and more glucose builds up in your bloodstream, and you get high blood sugar levels. So why do some people develop type 1 diabetes? Well, this is the million-dollar question. So usually when I'm talking to medical students, they will, if I ask them, what's the cause of type 1 diabetes, most people will say that it is genetic. And I will then say, well, if your mum has type 1 diabetes, what do you think the chances are of you developing it? And I won't say that everyone always gets it wrong, but I think a lot of people do think that type 1 diabetes is very much inherited. But of the two types of diabetes, it's probably the least inheritable. And what that actually looks like is that if your father has type 1 diabetes, your chances of developing type 1 diabetes are 1 in 17. If your mother has type 1 diabetes, the chances are between 1 in 25 or in 1 in 100. If both your parents have type 1 diabetes, your risk goes up a lot. And then there are also conditions whereby there are other autoimmune conditions associated with type 1 diabetes, and the risk then can be really very high. And in 1 in 7 people with type 1 diabetes, they have this syndrome, which means that they have other autoimmune diseases, and their children have a very high risk of developing type 1 diabetes. So the risk is elevated, but it doesn't mean that just because your parents have type 1 diabetes, you'll get type 1 diabetes. So this tells us that the environment must be playing a part in the development of the condition. We know in terms of genetic backgrounds, there are some HLA associations. So HLA is a major histocompatibility complex, and it's found on the short arm of chromosome 6. And in white populations, HLA-DR3 is associated with type 1 diabetes, and in African Americans, HLA-DR7, and in Japanese populations, HLA-DR9. So this means that by looking at people's DNA, you can understand whether people have a risk, but it does not automatically mean that they will develop type 1 diabetes. So what are the environmental triggers? There have been many observational studies and interventional studies that have tried to understand what it is about the environment that causes type 1 diabetes. What we know about type 1 diabetes is that the incidence of type 1 diabetes is going up. It's now at about has a yearly increase of about 3% year on. And it's thought that by 2040, the incidence will be much higher than it is currently and will be doubled. And so this again tells us the environment is playing a key role to play. Some things that have been examined in terms of environmental triggers are things such as vitamin D and sunlight exposure. Type 1 diabetes is more common in countries which are away from the equator, so northern countries, such as Scandinavian countries and Scotland, etc. So there's been a lot of interest as to whether a reduced exposure to sunlight or reduced levels of vitamin D are associated with development of type 1 diabetes. There have been interventional studies, but this has all been thought to be, the effects have been thought to be very minimal. Other interesting facts are that if you migrate from a country which has a low incidence of type 1 diabetes to a country that has a higher incidence of type 1 diabetes, you inherit the increased risk of the country that you have moved to. So this suggests that there's something to do with the environment, again, that is playing a key role in the development of type 1 diabetes. One of the theories is based on an idea that if you're brought up in a rural environment, such as a farming environment, your risk of type 1 diabetes is quite low, but when you move to a city, your risk again goes up. So there's some sense that there may be something about priming the immune system, which means that when you're living in a less clean environment, your immune system is less reactive to your own cells. But again, a lot of these things have been identified in studies, epidemiologic studies, which is just looking and observing to see who has an increased incidence. But interventional studies have been less useful in terms of identifying what these key environmental triggers are. Another more recent theory, which is intriguing, is one which thinks about the increase, the changing food environment that we humans find ourselves in. And there is an idea that the effect of metabolic stress on the beta cell, so that is, if you like, expecting the beta cell to produce lots of insulin all the time in response to a high caloric load, a lot of food, a lot of carbohydrate, somehow stresses the beta cell and places it at a higher chance of being involved in an autoimmune reaction with the body. All of these are unproven, including ideas. There are definitely ideas about viral infection being related to the development of type 1 diabetes, and also some theories around childhood immunization, although most are unproven. So moving on to what that means in terms of type 1 diabetes. So when people present with clinical diabetes, if you look back in time, it's highly likely that there is evidence of an autoimmune destruction, and evidence of immune attack on the beta cells at least 5 years before presentation. But what this is also important to understand is that the destruction of the beta cell function, these are the cells that produce insulin in the pancreas, goes on over a period of time. And so that at a point where there is a genetic predisposition, which can be identified, once you get immune activation, there is this slow decline in beta cell function, so that by the time people present with clinical diabetes, and what we mean is they present with high blood sugars, they're thirsty, they have infections, they may have developed a condition called diabetic ketoacidosis, very little of the beta cells are actually functioning. And so what we have to do is therefore replace insulin. And this has been the key way of approaching the treatment of diabetes since the discovery of insulin in the 1920s. And what I'm going to talk about today is how we are slowly but surely moving away from the idea of insulin replacement to the idea of beta cell salvage, beta cell replacement, and prevention of immune attack. So this panel shows the discovery of insulin, which is attributed to Banting and Best, and for which they received a Nobel Prize in 1923. They built on the work of many physicians and scientists who had been working on the cause of diabetes for up to 30 years. And there's another panel there showing Oskar Minkowski, who was born in 1858. And he was instrumental in identifying that the pancreas was the place where which something was released that caused a lowering of the blood glucose level. And what Banting and Best were able to demonstrate with patient JL was that with the injection of insulin, he went from a child who it was unlikely to survive. The chance of surviving type 1 diabetes in the 1920s was about, had a worse prognosis than most cancers. It was likely that people died within 4 years, and he then gained weight and was well, and then lived for many years after that. What's also very interesting with Banting and Best is that they sold the patent of insulin to Toronto University for $1. And they reflected that they felt that something that was so important for the health of mankind should be gifted to people rather than be sold. And it was because of this altruistic step that insulin became very widely available very quickly throughout the world. And in fact, the University of Toronto charged the MRC in the UK to deliver the production of insulin. And I was very privileged to meet people when I first started working in diabetes who had been some of the first people to receive insulin and had lived a long life. And so what is it that we need to do when we're giving insulin? And I want to make the point here that what we're trying to do with insulin and the management of diabetes when we're injecting insulin has not changed at all since it was discovered in the 1920s. So the cartoon shows the peaks of glucose levels when people eat. When you eat carbohydrate, your blood glucose level goes up, and then it comes down again if your pancreas is working. You also release a background amount of insulin, which inhibits the breakdown of storage products, which will also give you glucose in your blood so that your brain and your heart, etc., can work. Insulin, when you inject it, is to mimic this. You have a background insulin, which works to prevent the release of glucose into the bloodstream, and then you take insulin, which covers the food that you've eaten. Now, what does that mean for the individual and the person living with diabetes? It means that they have to check their glucose level. They have to know what the level is. They then have to have their insulin to hand. They have to look at the food that they're going to eat. Then they have to do quite a complex maths calculation, and then they have to decide how much insulin they're going to give themselves. Now, this happens every day, all days, all the time. If you have a child with type 1 diabetes, as a parent, you'll be supporting your child to do this. And what's happened since the 1920s is that the delivery devices are much more streamlined and useful. And also we now have, in the last 4 years, widespread use of a Freestyle Libre flash glucose device, which people can wear on their arm and will give them a constant readout of blood glucose. However, all this is doing is giving people more data and more information so that they can calculate their insulin doses. It's not doing it for them. And I think what I'm really struck by when I'm working with people with type 1 diabetes is that thinking about diabetes takes up a lot of bandwidth. It means that when other things are going on in their lives, this still has to remain number 1, 2, and 3 of their priorities, which can be extremely difficult. So the panel on the right-hand side is a download from a Freestyle Libre kindly shared from one of my patients. And this is my patient's attempts to keep their blood glucose level within a certain range. The grey range, which is between 4 and 10, is the level that we expect people to keep their blood glucose in about 70% of the time. That would be diabetes control exactly where you would want it to be. But note, only 70% of the time. And that's because the insulin is not quite fit for purpose. The insulin that we inject is given into the subcutaneous fat. It has to go all the way around the body until it gets to its point of action. It can be affected by its absorption can be affected by exercise, by heat, etc. So it's not particularly fit for purpose, but it is ultimately, although there have been slight changes in the way that insulin is configured, it doesn't work quite quickly enough. Now, the panel on the left-hand side is shared by Dana Lewis, who is a programmer who has been working on the automation of insulin delivery for about 20 years. And what this cartoon is demonstrating is that however you get your data, when it comes in manually, you have to do the maths and then you have to deliver the insulin, whether you're delivering the insulin in a pump, which is another way of giving insulin, or whether you're injecting it. But that an automated system which reads glucose from a sensor and then tells the pump what to do actually is where the preference would be. And so one of the newer developments in type 1 diabetes, which I want to share tonight, is the technology for diabetes and the development of the hybrid closed loop. Now, very simplistically, this represents three parts: a pump which delivers insulin into the subcutaneous tissues, a sensor which makes a record of the blood glucose levels, and an algorithm that sits in the middle of it. Now, to many people, and certainly many years ago when I was working in research, one of the physics postgrads that I was working in said, well, surely this can all be automated. This is crazy. Why are people having to think about what they have to do? And I think that there's been a very strong desire to automate this for a long time, but these devices are medical devices and they have to be 100% safe. So what has taken time is the development of these devices and the money to develop them. Because although type 1 diabetes is a disease that most people have heard of, it isn't exceptionally common, and therefore the companies that develop these devices have needed to know that they will that their investment is going to reap them profit. What's been incredibly helpful in this space is charities have been working as lobbying organizations to encourage the manufacturers to undertake the research. And really what has happened in the last couple of years is that these are now much more widely available and have been received their FDA approval. So the panel on the right-hand side is a download, again, kindly shared by one of my patients, of a hybrid closed loop. I think the first thing you'll see is that blood glucose levels are basically within the parameters of under 10 nearly all the time. When you look at the bottom, you see OP5 basal. This represents the background insulin that is being released by the pump. And the red areas are when the pump is suspending, because the sensor has fed into the algorithm and the algorithm has suspended the insulin from being infused. Now, what is really interesting about this, and I won't go into a lot of detail, is that I don't think that anybody would be able to know that they would have to suspend their pump in the frequency that you can see at the bottom there. It's what we're asking our patients to do is try to mimic this type of automated system, but it's just not possible. And therefore, this is why it's highly unlikely that people can achieve the blood glucose levels within these parameters manually. With these devices, they are still not 100% automated. People still have to announce carbohydrates. So if they're eating carbohydrate, they have to let the pump know that they're doing so and how much. And they also have to announce exercise, but they would expect to be in range at least 70% of the time. This is one of the most recent trials from the hybrid closed loop therapy. And what was necessary to demonstrate was that this technology was better than injecting insulin and using a sensor which is attached to the arm. And they demonstrated that it was in fact superior. And of course, when you are asking the NHS to pay for this type of equipment, you have to be able to demonstrate that it is superior and gives benefit over what is available currently. And this is in fact what's happened. And in early November, NICE, who are the organisation who advise the NHS on what the NHS should consider to provide, recommended that hybrid closed loops are available for those people who have an HbA1c over 7.5%, 58 millimole per mole, or for people with problematic hypoglycemia. Now, in North Central London, I have estimated that this is actually about 3,000 patients. And if we think about the cost of this, consumables, which are just the parts of the system which you use and then you dispose of, cost £1,000 per person. So even just to provide the consumables for 3,000 people at £1,000 a year is expensive. The equipment costs about £8,000 over a 4-year period. So we are looking into millions. And so the NICE have in fact recommended that the NHS is allowed to have 5 years instead of the usual 90 days in which to consider how they will offer this treatment to people living with type 1 diabetes. Now, just to mention to the disruptors, this is a group called Night Scout, which Dana Lewis was part of. And this is a group of people who have built their own automated looping systems. And what you can do is you can go to Night Scout and you can download the software that is required, the algorithm that manages the blood glucose levels. And essentially it requires hacking into the sensors and into the pumps which are available commercially. It's not been tested, did not go through the same formal testing that the commercially available closed loops have gone through. But actually it's now increasing, these systems are being increasingly studied. And I think they are really, really interesting. And this is particularly powerful and helpful in places where there isn't a government-funded healthcare system and people don't have insurance to pay for the systems themselves. And so now I'm going to move into the next part of my talk, which is we've talked about how to replace insulin. We've talked about the more usual ways of replacing insulin with injections, replacing insulin with pumps, and using sensors and augmented systems to do that. Stem cell replacement is when a stem cell is crafted to be a cell that responds like a beta cell, for instance, and releases insulin in response to rising blood glucose levels, and therefore takes over the action of the injected insulin. Now, type 1 diabetes is seen to be the low-hanging fruit in stem cell therapy because we know which cell has been damaged and we know what it does. But most importantly, there's been a program running for at least the last 14 years, which uses islet cells from deceased individuals and gives them back to people as a transplant for the treatment of severe and recurrent hypoglycemia. And this is a transplant program which I'm the lead of at the Royal Free. Now, Doug Melton, who developed the stem cell research, did so in response to his son being diagnosed with type 1 diabetes. And he thought at the time it was going to take him 5 years to design a cell that would work. He sold his biotech company to Vertex, and they have now brought this into the clinical trials space. And this gentleman is the first in human to receive the VX880 phase 1 trial. The trial was reported this year, and so far 6 people with type 1 diabetes at 90 days have shown improvement in all parameters. There are a couple of other products which are also being trialed, VX264 and ViaCyte, which use either encapsulated islet cells or islets which have been had an alteration in their immune status. And so confident, it seems, are the idea that stem cell replacement will be available is that a very large manufacturing facility is being built in the States to produce these stem cells. And although people still need to take immunosuppression, that is, they have to take drugs which reduce their response to these cells to prevent them from being rejected and damaged, for many people, this is a very attractive therapeutic option. And also when we think about the cost involved in hybrid closed loops, it's possible that there will be a tipping point where this kind of therapy becomes more cost-effective than and preferable to people living with diabetes than devices. So when we think about the progression of diabetes, we've talked about the clinical diabetes, but I think we should finish now by thinking about strategies to preserve beta cell function. And a lot of work which has been championed by the Type 1 Consortium has been to look at trying to preserve beta cell function either at the point of the diagnosis of clinical diabetes or earlier in its clinical presentation. So type 1 diabetes is now has now been characterized into four stages. Stage 0 is not type 1 diabetes. Stage 1, 2, and 3, with stage 3 being clinically evident type 1 diabetes. And the patients are characterized looking at antibodies which are known to characterize the presentation of type 1 diabetes. The first ever immunotherapy for type 1 diabetes, teplizumab, received an FDA approval in November 2022, and it's now been considered in Europe as well. It delayed development of diabetes by approximately 3 years for those with stage 2 diabetes. Now, what this means is that these people have evidence of autoimmunity with antibodies present, and they have an abnormal test when challenged with glucose, but they do not have evident type 1 diabetes. And this drug is now being trialed in stage 4, meaning that in people with clinical diabetes, it's being trialed to see if there's any opportunity to salvage any of those beta cells, which may still be working at presentation. It is a monoclonal antibody binding to CD3 surface antigen to prevent the immune attack. This is the data from the trial, which looks at the proportion of people free of type 1 diabetes against time, and it demonstrates that that teplizumab has a positive effect in reducing the presentation of type 1 diabetes in this group. So this was incredibly exciting, and on practical terms, the drug was in, I think, 2 or 3 infusions of a drug, and then that was it. So this was able to put off the time at which somebody was having to move to manage their diabetes with injections and checking their blood glucose levels, which is obviously quite significant. So this is the PAIRS building. This is a joint initiative between UCL, Royal Free Hospital, and Royal Free Charity. And in this building is my collaborator and her team, Professor Lucy Walker, who works to look at the immune regulation in type 1 diabetes. And she and I together are going to be working, have applied for a grant, been awarded a grant in the Type 1 Grand Challenge, which will look to understand the effects of drugs which can effectively modify the type 1 autoimmunity and presentation of type 1 diabetes. Of course, when you are trying to understand what diabetes looks like before you present with high blood glucose levels, you need to be able to screen effectively for it. And I now want to present some work undertaken by a colleague of mine in the University of Birmingham, who is also a professor, an honorary professor at UCL, Dr. Parth Narendraran. And he has developed a study which will be looking to screen those with type 1 diabetes as children. This is called the ELSA study, and what it will be doing is checking dried blood spots from individuals who opt in, looking for those antibodies that help understand whether people are likely to develop type 1 diabetes, and then invite them to come in for staging of regular glucose checks. And it is hoped that if this is demonstrated to be effective, this will be a model for how we can screen large populations of people with type 1 diabetes and offer them interventions to prevent the presentation of type 1 diabetes. And that's further information for those people who are interested. It's worth saying, if you only screened the people who are whose parents have type 1 diabetes, you would only ever find 20% of the people who are going to develop type 1 diabetes, and that's why it has to be a population-based piece of work. So in conclusion, this is an exciting time for therapy for type 1 diabetes. The NHS is likely to approve the effective treatment with hybrid closed loops. Large studies have been conducted for diabetes prevention, and guidelines for trial design in type 1 have been proposed so that those at risk can be identified. And there is a review article there for those people who are interested. I'm going to stop there now and hand back to the chair.
Thank you so much for that fascinating lecture. That was really, really good. Thank you so much. Just to remind everyone, we do have a question and answer session now. So if you have any questions, please submit them to the question and answer tab at the bottom of your screen. So we have one question that one of our guests have asked. The question goes, seeing the teplizumab immunotherapy displayed on screen, does the isumab or mab suffix indicate a particular class of medications? I've heard of crisanisumab, sorry, I can't pronounce that very well, for sickle cell disease, and donanemab for Alzheimer's disease.
That's a really good question. I think the mAb is basically the monoclonal antibody part of it. And this has been designed specifically with type 1 diabetes in mind. And there's a monoclonal antibody for most conditions, ultimately. And it's just a way of interfering with the immune system to prevent immune attack.
Perfect. We have another question on the ELSA study. So what is the benefit of having of screening people for type 1 diabetes over them presenting later, for example?
So that's a really good question. I think that one of the key focuses of treatment of thinking about type 1 diabetes is prevention. And so the idea is that if you can identify those people who are at risk of developing type 1 diabetes, and you can do that reliably, then you can offer them an intervention. And although that intervention may not work forever, it will put off the time at which people are dependent on having to treat the diabetes themselves. And what this can mean is that for instance, for children particularly, it can mean that rather than having to self-manage and look after their diabetes at the age of 8, this might be at an older age. But also because it's likely that one immune therapy will work for a short period of time, and then or for a period of time, and then there'll need to be another rethink to consider a different form of immune therapy because there may be tolerance. It's important to kind of understand who the population are, and with any screening intervention, you have to understand is it acceptable? Does it identify the people who it's supposed to identify accurately, and the people who are not going to develop type 1 diabetes, are they identified accurately as well? And my colleague's study is really beginning to do that. And the first part of his study is to see whether or not taking blood spots and testing at home and sending this in and inviting people to come in for glucose tolerance tests, is that acceptable to parents and their children when they don't actually have the condition?
And just to clarify, so if you are at risk for developing type 1 diabetes, if you manage your glucose before the diagnosis, it can delay the progression?
No, I think the idea would be that it will. Currently, there are no lifestyle interventions which are understood to be effective. I think what this is looking at, it would be a pharmaceutical intervention with some kind of immunomodulating drug.
Okay, perfect. Thank you very much. We have a question about how is diabetic ketoacidosis caused?
So that's a really good question. Diabetic ketoacidosis, or DKA, is when patients are found to have usually very high levels of glucose in their blood, and also they have ketones. Ketones are acidic and cause the pH in the blood to drop, and this affects all of the bodily systems and is life-threatening. It's a life-threatening and diabetes emergency. What happens is when it happens as a result of low insulin levels, and when the insulin levels are very low, it means that the glucose is not driven into the cells, but it also means that there's ketone body formation due to breakdown, and that's why it happens. And so when you restore the insulin, this restores the situation with the glucose levels going back, coming back down, and the inhibition of ketone formation.
Perfect. Thank you so much. So we have a question about stem cells. First of all, the commenter mentioned, thank you very much for the lecture. It was really interesting. So why are stem cell therapies only valid for 3 months? Is it because those cells die, or because of T-cell mediated attack again on B cells?
I think you're referring to the 90-day study that I reported. It's actually because in that study, 2 people have been reported, their data has been reported for a year, and the remaining are for 6 months. They wouldn't be, I think the hope is that stem cells will last a lot longer than that, because they'd be very expensive. But the study, as released by the company, has only reported data to those time points in all participants. But I believe that the study is still ongoing, so there will be more data.
Perfect. Thank you so much.
In fact, interestingly, their first release of their data was actually in the New York Times and not in a medical journal.
Oh, wow.
So we will wait, we all have to wait to see the robust clinical data in peer-reviewed journals to be sure and to know that these are effective cells at producing insulin.
Perfect. Here we have a question about how long does it take for type 1 diabetes to develop?
That's a really good question. Probably about 5 years, but the attrition or the destruction of the beta cells can be faster and slower in different people. And so in type 1 diabetes, although we think of it as a disease of childhood or a condition of childhood, 50% of people present with type 1 diabetes as adults. And although the majority of those people are under 30, adults who are over 30 tend to present with what is considered to be a much more sort of milder presentation. The destruction of the pancreas and the beta cells is much slower and can be over 10 to 15 years, and that tends to be referred as a different condition, which is called LADA, latent autoimmune diabetes of adulthood.
Perfect. Here we have, I think, another question on ALSA. So, sorry if it skipped. How feasible is it to test large parts of the population for the risk of developing type 1 diabetes?
Well, that is a really good question, and that's exactly why the study is being undertaken by Professor Miranda. So the study, I think, is being undertaken in North Central London, also in Birmingham and one other region. And it's asking exactly that question. How feasible is this? How likely are people to want to have their children tested? Will their children want to be tested? And how feasible is it for those individuals who are then tested to have serial glucose tests after that? And I think we don't know, because I think part of answering that question will be how effective are the drugs at preventing it? But they come hand in hand. So without knowing how feasible the screening is, we will probably never know how acceptable and effective the drugs are.
Yeah. Okay. Here we have a question about stem cells. How ethical is using stem cells in treatment for diseases like this? And how viable do you think stem cell therapies will be in the future of medicine?
Oh, that's a really big question. So I'm not a regenerative medicine expert, but I think that my experiences in type 1 diabetes, the people who receive islet transplantation are people who, despite best medical therapy, so that means despite the pumps, the sensors, effective support, education, they are still having problems with their diabetes. And what we mean by this is they are getting recurrent severe hypoglycemia. And the stem cells would be for this particular group. For islet cell transplantation from deceased individuals, there is a limit to how many islets you can isolate from somebody who's deceased, because the pancreas may be affected by whatever condition caused death. but also they are more immunogenic. So there are often you have to have 2 transplants, but over 5 years they may not be working. So there is a limited product. So what stem cells do for type 1 diabetes is they allow a more reliable product for people to be transplanted. But I think it would only ever be for people with recurrent severe hypoglycemia, or that's certainly where it's sitting, and that's certainly what the trialists are examining. Certainly in the 880 trial, I think there are they have been using them in a phase 1 in a slightly different context, but I don't think cell therapy would, in this particular context, would ever be for everyone with type 1 diabetes. It would be for those with recurrent severe hypoglycemia.
Perfect, thank you. Here we have a question about your medical research and things like that. What made you go into medical research, and what made you want to specialize in diabetes?
So that's a really interesting question. So I'm interested in diabetes, I think, because it's one of those, it struck me to being, often you just become inspired by somebody you work with, I think. And I worked with somebody when I was doing my diabetes in a very challenging environment, and she was an excellent physician, and I could see that by being a good communicator and being supportive and listening to people who you're working with, you could actually make a big impact. And I then had the opportunity to work in the early days of neuroimaging, and was looking at the effect of hypoglycemia on brain function, which was enormously exciting. So that was really where I came into my research with diabetes. But I think where I then moved into, from having done a PhD, I then went back into clinical work, and then worked within a clinical service to run the islet transplant service. My research really now very much focuses on ensuring that the patients that I'm working with have access to clinical trials. So making sure that there is the opportunity for people who live with diabetes to take part in clinical trials of all types. So I think that answers your question, I hope.
Yeah, that's perfect. Thank you so much. And what made you go to research?
So I'm not really a researcher. I did a period of research. It's very normal for people who are NHS consultants to have done a period of research. I've got a PhD, so I spent a bit longer in research. And I think that for working in diabetes, it's essential to have a really good understanding of the research world, but how research studies are conducted. What most NHS consultants then will do alongside their NHS service delivery is they may work with pharma to run phase 3 and phase 3 clinical trials for new drugs. They may work on hypothesis-driven research with basic scientists, which is what I'm doing with Lucy Walker. And then I've also got another collaboration working in eating disorders and type 1 diabetes. So my research interest is a clinical one rather than a lab bench-based research.
Perfect. Thank you. I have a question here about identifying patients with diabetes. So a commenter has said that they've seen patients age 2 with type 1 diabetes. How can one identify patients early, so when they're very young?
Yeah, so that's a really good question. So I'm not a pediatrician, but it's weight loss. So one of the most characteristic presentations for most people with type 1 diabetes is accelerated weight loss, plus the signs of having a high blood glucose, which are thirst, and passing a lot of urine. And in children, that's often the development, if they have been continent, becoming incontinent. I think it's quite difficult with a 2-year-old actually, but those would be the being generally unwell, and losing weight and failure to thrive. But I think the idea of the ELSA program is very much that the presentation of diabetic ketoacidosis, which is when people get to the extreme presentation with very high blood sugars, is actually life-threatening. And the UK has a very high incidence of people being diagnosed with type 1 diabetes in DKA, meaning that it is not being picked up earlier. And so I think that a lot of what the screening program is trying to do is to make sure that children are identified early when they are developing type 1 diabetes.
Perfect. So here is a question about symptoms. So you mentioned the treatment that was shown to delay the manifestation of symptoms. Is the treatment given routinely nowadays for people in early stages of diabetes?
Is that the teplizumab? I think that's referring to the teplizumab. I'm not sure about routinely because it's not available in Europe at the moment. We're still waiting for approval. I think in the States it's becoming more widespread, but again, I don't believe that they have an effective screening program. So again, it depends on identifying people with stage 2 type 1 diabetes, which means before they have presented with symptoms. So unless you were screening people and you had a screening program, you wouldn't know. Unless you were screening the offspring of people who come from families where there is more type 1 diabetes. As I mentioned in my introduction, there are about 1 in 7 people with type 1 diabetes comes from a family where there is a high incidence of type 1 diabetes.
Perfect. How does the role of diet, particularly carbohydrate intake, come into prevention?
Not really with type 1 diabetes. So type 1 diabetes is not a condition that is associated traditionally with being caused by food intake or dietary, particularly carbohydrate intake. But I think what I did say is that there is a lot of interest on beta cell stress. And I think that what we're looking at here is sort of a population effect. And what we don't know is if that's the issue within individuals. You know, if people are eating gain a huge amount of weight, they become very insulin resistant in a particularly high risk group, does this somehow cause beta cell stress, which then can lead to an autoimmune activation? But it is very preliminary, and I say it hesitantly because I think a lot of people with type 1 diabetes, people I've worked with, feel that they are often judged by what they eat. They are open to comment by many, many people to say, you know, can you eat that? Shouldn't eat this. And I think that really, that's why it's a really important message that type 1 diabetes is not caused by what you eat, but there may be a population-based effect.
Perfect. So here we have a question about stem cells again. Do you think that, or actually, never mind. So do you think the NHS should prioritize clinical trials over the treatment of current patients?
I don't think that one is against the other. I think that the academic health sciences centres, of which UCL Partners is one, their remit was to ensure that the local population had access to clinical trials. And I think that it is seen, it's certainly viewed that access to clinical trials for people living with certain conditions is a reflection of the quality of the care that they're receiving, because it means that people have the opportunity to take part in what could be a new development for their condition. Certainly the way that it works is that clinical trials are an add-on extra within the NHS, in that they are not delivered. A clinician would not be doing a clinical trial rather than doing a clinic. So they're sort of, they are symbiotic, and actually, you know, the aim and the mission and the vision of most clinicians will be to be able to offer the people in their clinics clinical trial opportunity to join into clinical trials.
Perfect. And then I do have the stem cell. So 2 questions sort of combined together. So has there been any thought or any actual clinical trials that have implanted stem cells that have already been modified into beta cells?
Yes, that's what the trial was that was reported on in October. These are stem cells that release glucose and release insulin in response to rising glucose and stop releasing insulin when the glucose goes down. So yes, they they won't be exactly the same as beta cells, but they've been modified to be beta cells. That's exactly what they are, yes.
Perfect. And in terms of research, as a researcher, when treatment-specific research lasts for a long time, do you move on to different research projects or new research projects simultaneously, or do you have to stop one and then start another?
I think it just depends. I mean, some NHS consultants will have time in their week where they undertake research, and they will probably dedicate themselves to a specific trial. Most trials are time limited, so 2 years or 1 year, etc. And then they may move on to a similar topic, or they may take on a different clinical trial. But most consultants will have a particular interest in a particular topic, and therefore they will tend to gravitate towards those sort of trials. So for instance, at the moment I've got a trial that's active looking at the effect of exercise on type 1 diabetes, but also another trial looking to offer people some mechanistic studies to look at the effects of drugs in type 1 diabetes. So it really just depends on time and opportunity, I guess.
Perfect. And in terms of pancreas transplants, do you think that could be an effective treatment for type 1 diabetes?
So pancreas transplant is offered to people who have type 1 diabetes with recurrent severe hypoglycemia. It's the same indication for people who are offered islet cell transplantation. But this is for people with recurrent severe hypoglycemia. The pancreas transplant is a very big undertaking. There's an elevated chance of actually dying during the procedure. So the real clinical need for it is thought about very, very carefully before offering it to somebody. But again, both islet cell transplant and pancreas transplant are limited by availability of organs. So this is why the stem cell work is so interesting, because this starts to get around the issue of availability.
Perfect. And given that we only have 2 minutes left, I'm just quickly going to ask one last question. So I guess this is similar to what I asked earlier. If ELSA detects someone at risk of developing type 1, what are the preventions that can stop them?
At the moment, there's none that are available to be prescribed, but there are drugs coming into phase 2.
Okay. Fantastic. Well, we're out of time and we'll need to leave it there. However, if you would like to please provide us with feedback about today's session, we would really appreciate that. You just have to fill out our survey, which will be sent to you following to today's event. You should receive that via email. Thank you for all your comments and amazing questions. And thank you very much, Dr. Miranda Rosenthal, for an amazing and excellent lecture. Have a great evening, everyone. Thank you very much.
Thank you.